what I'm going to do is I'm going to take you through some of the things we've learnt about the pathophysiology of the vascular supply in cancer through using anti-angiogenic therapy. And in overview, the topics we're going to cover are: what is anti-angiogenic therapy? How is angiogenesis targeted in cancer conventionally? I'm going to spend some time talking about resistance to anti-angiogenic therapy. We've heard about that a little bit already. I'm also going to talk briefly about how you might go about predicting who will respond. I'll also touch briefly on duration of therapy. I'll also talk briefly about how these therapies might interact with chemotherapy, but I won't label this point extensively because I'm sure that Bob will go into this in more depth. And I'll also talk very briefly about what the consequences of VEGF, targeting VEGF could be on other systems in the body. So to just overview, what is anti-angiogenic therapy? So conventional dogma tells us that when a tumour is small, it gets most of the oxygen and nutrients it needs from local pre-existing blood vessels. But as it grows, it begins to release pro-angiogenic factors such as vascular endothelial growth factor. And these pro-angiogenic factors bind to, I'm not sure if it's advancing, sorry. Bind to receptors on, VEGF receptors on these vessels. And this results in the sprouting of vessels which then grow into the tumour, vascularize the tumour, and this process is thought to be required for tumour growth. So, as Professor Jana already alluded to, the process of angiogenesis, new vessels which grow from pre-existing vessels, that occurs in a tumour is essentially, we believe, the tumour reactivating a process that's already active during the process of development in the animal. And you can see actually from this, you've seen this picture before, this beautiful picture of a transparent zebrafish in which the vasculature is labelled with GFP so you can visualise it. And if I can get this video to work here, I don't know if I can get this to work. What this enables researchers to do is to video the process of angiogenesis in the living animal. And here you can see this is the aorta here, and you can see that these intersemitic vessels sprout from this aorta and grow and branch to form a vascular tree. And it's believed that this process is, if you like, reactivated in the cancer. So the cancer is reactivating a developmental process in order to provide a vascular supply. In order to visualize what this looks like, you can see here, this is actually a tumor from a mouse. This was a tumor subcutaneously implanted in a mouse. And the mouse has been injected with a dye that basically labels all of the vasculature. And all of these white structures here are the vasculature of the tumor. So you can see how this tumor manages to recruit a vascular supply which we believe allows it to grow. So based upon that concept, it was proposed many years ago now, mainly by Judith Folkman, but also other colleagues, that by blocking this process of sprouting angiogenesis, you may have an effective therapy which could be effective against all solid tumours, because it was believed that this process of sprouting angiogenesis is essential for the growth of all solid tumours. How do we go about trying to inhibit that? Well, this is just to show you basically, very basically, how the VEGF receptors are activated on endothelial cells. Essentially, the VEGF receptor here binds to a dimer of the VEGF. This then causes the receptor to dimerize. The receptor then becomes activated by phosphorylation of the intracellular domains. And then this leads to signaling, which promotes angiogenesis. So various different drugs have been designed to try and target this signaling. One is bevacizumab, which neutralizes the VEGF ligand, prevents it binding from the receptor. Another one is aflibercept, which is composed of soluble extracellular domains of the VEGF receptors and binds and neutralizes the VEGF ligand again and prevents it binding to the receptor. The third type of therapy is this antibody ramucirumab that's licensed in gastric cancer that binds to the receptor and prevents the ligand binding to the receptor. And the third is tyrosine kinase inhibitors, which inhibit the kinase activity of the receptors, and these include sunitinib and pazopanib and a growing range of drugs. So you can see how the various different strategies for targeting this receptor signaling have been adopted by different companies, and these drugs have been tested in patients. So of course, if we think about cancer, we can think about targeting different stages of the disease, and this is just illustrated here for breast cancer. Of course, in breast cancer, patients may receive neoadjuvant therapy prior to surgery to try and debulk the disease prior to surgery or prevent local recurrence after surgery. They also receive therapy in the adjuvant setting, the goal here being to try to stop micrometastatic disease developing to full-blown metastatic disease. And then also, of course, patients, unfortunately, who relapse with metastatic disease in multiple organs will also receive treatment for metastatic disease. And it was thought that anti-angiogenic therapy could be applied in breast cancer and in colorectal cancer and in renal cancer and in several cancers in these different disease settings, because it was thought that angiogenesis is essential for the growth of primary tumours, for the growth of micrometastatic disease and metastatic disease. Where are we now with this? And I'm sure Bob will touch again on this. Basically, these results haven't really panned out. So essentially, most of the trials that have been done have evaluated anti-angiogenic VEGF-targeted agents in the metastatic setting. In many cancers, this approach has not been successful, so in breast cancer, pancreatic cancer, melanoma. But however, there have been some key successes, including in metastatic colorectal cancer, metastatic renal cancer, and now gastric cancer, and several others. Unfortunately, we have less data in the adjuvant and neoadjuvant setting, but at least 4, I think 5 now trials of anti-angiogenic therapy in the adjuvant setting have failed to show a benefit. And these include cancers such as colorectal cancer, where there was a benefit in the metastatic setting. So we have to ask ourselves, is the vascular biology of micrometastasis different to metastatic disease? There are limited numbers of studies in the neoadjuvant setting. 2 in breast cancer showed some benefit of using bevacizumab prior to surgery in terms of achieving a better pathological response, but the effect was modest. So most of the activity is seen in certain types of metastatic disease. So this just summarizes that the anti-angiogenic therapies have had some successes in the treatment of metastatic cancer, particularly sunitinib in metastatic renal cancer, which has a profound effect on progression-free survival and overall survival in this patient as a single agent. And maybe this isn't surprising because renal cancers are extremely vascular disease and driven by an early mutation in VHL, which drives VEGF production. So these tumors are probably highly dependent upon angiogenesis. The addition of bevacizumab to chemotherapy has been shown to extend progression-free survival and overall survival in metastatic colorectal cancer, and actually that was the first approval for bevacizumab was in this setting. And more recently, of course, relevant to this meeting, ramucirumab has been licensed for use in metastatic gastric cancer. However, the problem is that many patients, as we've heard, present with intrinsic resistance to these therapies, even in the cancers where they're approved, and also acquired resistance, i.e. relapse of disease after an initial period response also is typically presenting in these patients. And the net result is, although you can achieve a survival benefit, the survival benefit currently is only typically measured in months. And as I alluded to, in several cancers, e.g. metastatic breast cancer, these VEGF-targeted therapies have been labelled as being fairly disappointing. Just to illustrate from the point of view of renal cancer, where these agents have single-agent activity, to show the kind of different responses you can see, this is for a retrospective analysis we did of some imaging data from patients with renal cancer who were treated with sunitinib or pazopanib. So these patients were imaged with arterial phase CT, which is thought to be a surrogate marker for blood flow in these renal cancers. And essentially, to simplify this, anything that's sort of red or yellow has a high blood flow, and green and blue is a lower blood flow. And here you can see a renal cancer lymph node metastasis in the chest that has a highly vascularized rim, but after treatment you can see that you really block this perfusion in this tumor, and this tumor shrinks very nicely. Here's a tumor in the pancreas where you can see vascular hotspots here, and essentially they've been that's been blocked by treating with anti-angiogenic therapy, but the tumour is still here. Essentially, it's stabilised. It hasn't shrunk. And then thirdly, here you have a lesion where after treatment, actually, this is a lesion in the liver, the tumour has actually progressed. And you can see that whilst there's very little vasculature perfusion in the middle of the tumour, at the edge of this tumour, it's highly vascularised and well perfused. So you can see that you get different responses to this therapy. You can get a very profound response in tumour shrinkage, stabilisation of disease, and also progression. This is a lesion that we managed to follow for longer. This was followed for up to a year and a half, and this demonstrates acquired resistance to therapy. So this is a lymph node metastasis in the chest. This is the border of the lesion here. You can see red is the vascular supply. After 41 days of treatment, this tumour's really shrunk, and now it's green, which shows that the vessels have really been shut off by the therapy. And this remains like this for almost a year, but then you can see by at about the year point, this tumour has regrown, and this is associated with a revascularization of the tumour, and that's why this tumour is now red. And then it continues to progress at a year and a half. You can see this tumour is regrowing. And this shows us that this illustrates very clearly how these tumours can respond and then rebound. And it's important to note that this patient was continuously on VEGF-targeted therapy, and so this tumour has somehow adapted to reintroduce a vascular supply, even though the VEGF pathway is being effectively suppressed. So actually, now we have a better idea about some of the mechanisms that may mediate resistance to these drugs. And this has been the product of many different groups working on this topic. And this is by no means an exhaustive list, but covers some of the things that we think may be going on. So firstly, we think that tumours can express a number of other pro-angiogenic growth factors beyond VEGF that can stimulate angiogenesis despite inhibition of the VEGF pathway. And these include basic FGF, PLGF, HGF that we've already heard mentioned, BVA angiopoietins, and many other pathways that may mediate endothelial survival even when you inhibit VEGF. And so just to illustrate that, so basically the VEGF receptor, when it's activated, promotes angiogenesis. You can inhibit that, but it may be that other factors such as FGF are able to come in and promote angiogenesis in its place. We did some preclinical work on this, where basically we modeled endothelial tube formation in vitro in the presence of VEGF, and if I can get this to run, you can see that I think it's over the course of about 24 hours, these vessel sprouts grow in the presence of VEGF very nicely. However, if you treat with this potent anti-VEGF drug, you can see that the drug very clearly promotes the regression of these vessels. So targeting the VEGF signaling pathway actually induces these vessels to retract. But if we did the same assay in the presence of VEGF and FGF, if I can get this to, oh, I can't actually, sorry. Why you should never show videos in a PowerPoint presentation. If we do the same assay in the presence of VEGF and FGF and sunitinib, we don't get retraction in these vessels, they continue to survive. And so this suggested to us that FGF is a potent factor that can provide a survival signal to vessels even when you inhibit the VEGF pathway. And in fact, there's quite a bit of data showing that in patients, a number of different pro-angiogenic factors are elevated in patients when you treat with these drugs, and it's thought that they may contribute somehow to resistance, perhaps by stabilizing the vessels. So there's also a thought that the endothelial cells themselves, the vessels may contribute in ways such as vessel maturation, so recruitment of parasites to tumours may render them less sensitive to VEGF, or as we've heard, actually endothelial cells might even be derived from tumour cells because transformed endothelial cells have been found in tumours, and endothelial cells have been shown to develop from tumour stem cells, and these might also be resistant to anti-angiogenic therapy. We've also heard that the tumour may recruit a variety of normal cells, such as myeloid cells, fibroblasts, or endothelial progenitors, which may contribute to resistance. And then another mechanism that I really want to focus on is other forms of vascularization, and particularly vessel co-option. So I'll talk about that very briefly. So as I said, when we think about cancer in blood vessels, we typically think about this process where the tumour stimulates the formation of new vessels which sprout into the tumour, is illustrated here. And conventional anti-angiogenic agents were designed to target this process. But in fact, pathologists have known for a long time that actually tumours can also grow around pre-existing vessels. And in fact, this makes a lot of sense. If you think there's a functional vasculature present in most host organs, if the tumour can invade around those vessels, then maybe that's an easy way for them to get hold of a functional vasculature. And we think that this process, which has been reported in liver, lung, and brain metastasis, i.e. all the sites that these tumours go and was associated with significant morbidity, and may explain resistance to conventional anti-angiogenic therapies. And my group and also Bob's group are very interested in this now, and we have some data to support this. I won't show that, but I'll show some of the pathology of these tumours to try and convince you this co-option is going on. This is work from Francesca Pizzella. This is actually reported in the 90s, so quite a while ago now. Basically, he reports different types of vasculature in breast cancer lung metastasis. So this is a CD31 staining, it's a vascular staining of a normal lung. And you can see that what this shows is that the presence of capillaries in the alveolar walls here. And then these are the air spaces of the alveoli. And he reports two different types of tumour. One type of tumour where the vasculature of the tumour is very different to this. It's very abnormal and irregular. And this is very typical of angiogenesis, new vessel growth. But he also reported another form of lung metastasis where, if you look, the vascular architecture of this tumour is essentially the same as these alveoli. And he proposes that what happens here is the tumour cells merely grow within the alveolar spaces without inducing angiogenesis. And so tumours can induce angiogenesis in the lung, but they could also potentially use pre-existing vessels. And whilst it's not really clear whether these vessels would respond to anti-VEGF therapy, we believe that if they are pre-existing vessels that are co-opted, it's quite likely that they would not. This is also a striking example in the brain where I think this has been probably most closely studied. This is an animal model of breast cancer brain metastasis. Here's the macroscopic appearance of the tumour. Tumour cells are in green, and the vasculature of the is in red. And here's the normal brain vasculature, and here's the vasculature of the tumour. So not only do these vasculatures look very similar, if you zoom in very close, you can see here a vessel here in the normal brain, and that the way the cells actually cluster and grow along this vasculature. So we think that this is not a process of angiogenesis. This is merely tumour cells growing along pre-existing vessels. And clearly, if that's going on in metastatic sites, this could have profound implications for trying to target new vessel growth. If tumours can just grow around pre-existing vessels, then this may explain why VEGF-targeted therapy doesn't always work as well as we might like. So I'll just track back, actually, just to say that there are also, of course, the role of the tumour cells in resistance to anti-angiogenic therapy cannot be ignored. As we've heard already, it could be that tumours can actually adapt to the conditions of to conditions of hypoxia and nutrient withdrawal that you would see under the presence of VEGF therapy. It may also that they actually become more aggressive under this therapy, or their biology changes in a way that may explain why we see eventual resistance. And although I won't dwell on it, there's potentially many pharmacological mechanisms through which these drugs may not work as well as we would like, including recent data showing that tumour cells may actually sequester kinase inhibitors, which may lead to reduction in the availability of these drugs and allow tumours to progress effectively by reducing the concentration of drug that's present. So I'll just move now to talk very quickly. So essentially, to cut a long story short, currently there are no validated biomarkers that can be used in the clinic, as far as I know, to predict who will respond to these drugs. And I think that reflects the fact that the biology of targeting this pathway is very complicated. It has been suggested that circulating levels of VEGF may be a predictive biomarker, and that's certainly being tested prospectively now in metastatic breast cancer. But it may be that circulating levels of multiple factors may be more relevant, and certainly there's some data in renal cancer to suggest that if you look at a panel of circulating cytokines and growth factors, this may be predictive of response in that setting. There's also been a lot of interest in looking at polymorphisms in individual members of the VEGF pathway. There's been data showing that different alleles of VEGF may be associated with benefit of these drugs. But I think probably we need to look at the whole genome of these tumours actually to really see if there are signatures that predict for response to these drugs. And certainly there's some evidence in ovarian cancer that that's unpublished that gene signatures may be the way to go to predict response to these drugs. There's evidence in patients that an increase in hypertension may be associated with response to these drugs, which is an interesting possible biomarker. But certainly that's something you'd actually have to treat the patient to see that effect before you'd be able to use it as a biomarker. And also, although I won't dwell on it, I think there's enormous potential that's been explored but needs to be explored further to use imaging as a way of stratifying patients for treatment of this therapy. Perhaps blood flow or tumor morphology or other features of the tumor texture may be used to predict response. And certainly if you think about if co-option is a mechanism of resistance to therapy, you could imagine that maybe you can stratify patients based upon those tumors that use angiogenesis and those that co-opt the vasculature to separate out responders. But that's just my personal theory. So just very quickly on duration of therapy, there's been some interesting data, and this was alluded to already, and this was from the group of Donald McDonald, showing that actually probably you need to maintain VEGF therapy in order to get the benefit. So they did some very neat experiments where they stained here for the vasculature of a tumor. They're then treated with a potent anti-angiogenic drug and showed that 7 days after treatment, you see this potent reduction in the vascular supply of the tumor. But then they took away the drug and looked 2 days later or 7 days later. And they showed that essentially, once you remove the drug, the vascular supply returns. And so if you inhibit vascularization, obviously you get a reduction in vessel density. But if you then take away that drug, the vasculature can come back. And this suggests that maybe you need to maintain continuous anti-angiogenic therapy in order to achieve a benefit. Some data for this has been obtained clinically. This is a retrospective analysis of patients with colorectal cancer that received bevacizumab. And so what was looked at here, and there are about 2,000 patients in this study, what they did was they looked at patients that got chemotherapy and bevacizumab and progressed. And what they were able to do is they were able to look at patients that either got no treatment beyond progression, they got some line of therapy beyond progression that didn't include bevacizumab, or they received some line of therapy that did include bevacizumab. And you can see that they got different survival outcomes. So those patients that got no treatment beyond first progression on bevacizumab and chemotherapy did the most poorly. Obviously, those who had some other line of treatment did better, but those that had treatment and had bevacizumab did the best. And actually, there's been now this is a retrospective study, but there was a prospective study to look at this. And indeed, they showed that if you continue bevacizumab before progression, continue bevacizumab beyond progression, you do see a survival benefit of about 1.5 months compared to not continuing it. So this provides some evidence that perhaps actually continuing these drugs beyond progression may be useful. And I don't know if there's any studies designed to look at that in gastric cancer, but this could be something important to take into consideration in that setting as well. So I touched very briefly on vascular normalization. We've already heard a little bit about this, but I think it's important to understand this because this could influence why anti-VEGF drugs work with chemotherapy or not, as the case may be, and I'll discuss the evidence for that. So what we know is that if we look at the vasculature of a normal tissue, it has a very organized structure, as we've already heard from Professor Dejana. But if we look at the vasculature of a tumor, on the other hand, it's very chaotic. One of the consequences of this is that actually this vasculature is not as functional as we would like. So, for example, just to illustrate this, this is a tumor where it has been stained for a blood vessel marker in green and a hypoxia marker in red. And this shows that whilst there are areas around these vessels that are well perfused, there are also areas that are very hypoxic. And this wouldn't happen in a normal tissue because the vascular supply is designed to maintain an equal distribution of oxygen to all tissues. But in tumours, this doesn't happen, and essentially we end up with this scenario. So one of the consequences that's been proposed by Rakesh Jain and co-workers is that if you have this chaotic vasculature, actually one of the problems with this is that this may actually impede the delivery of chemotherapy. And what they showed is that, interestingly, if you inhibit VEGF, you can achieve a normalization effect of these vessels, where the vasculature now appears to be more like a normal vasculature. And it was proposed that this may allow the better delivery of chemotherapy. Now, this has been a fairly controversial idea and has been used by many to try and explain why you only really see benefit with VEGF-targeted drugs when you give it with chemotherapy. But what is the evidence that really happens in patients? So, as I say, this is a controversial area, but this was a study published recently where a group in the Netherlands tried to validate this. So essentially what they looked at was tumour perfusion by using a radioactive tracer in patients that received bevacizumab. This is metastatic lung cancer, and actually over time what they saw is that bevacizumab reduced the perfusion in the tumour. And this is a very elegant study because they were also able to look at chemotherapy uptake in these tumours. And in the 10 patients they looked at in this study, in no instance did bevacizumab increase the delivery of chemotherapy to the tumour. In fact, in all cases, it reduced the delivery of chemotherapy. So this makes it very difficult to know whether actually vascular normalization is the reason why VEGF-targeted drugs tend to work better with chemotherapy. But it has been proposed that perhaps what happens is perhaps you overtreat. So maybe there's only a window during which you can normalize the vasculature with anti-VEGF drugs. And perhaps actually when you treat chronically with these drugs, actually you destroy so much vasculature that actually this results in the reduction of chemotherapy. But perhaps there are ways that you could normalize the vasculature in independent ways to achieve this effect. And this is the subject of investigation and some nice papers from the labs of, for example, Peter Carmelie, as we heard already. So I should point out here that this interaction between VEGF-targeted therapy and chemotherapy is unique to the drugs that really target the ligand and the receptor. The kinase inhibitors tend to work on their own. And so any theory that we have that really explains why chemotherapy and VEGF-targeted therapy work together has to take into consideration that subtlety. So I don't want to labour this point too much, but I think actually we really don't know why VEGF-targeted drugs work with chemotherapy, and I'm sure that Bob will touch on this more. Vascular normalization is one theory, but you could also envisage, if you sit down, a number of other explanations. So perhaps just using 2 types of therapy is better than 1. This is possible. Perhaps chemotherapy suppresses some resistant mechanism to anti-angiogenic therapy. So, for example, it's been proposed that chemotherapy might suppress the recruitment of myeloid cells to tumours that act a resistant mechanism for anti-angiogenic therapy. Perhaps the converse is true. Anti-angiogenic therapy somehow suppresses some resistance mechanism to chemotherapy. Or perhaps anti-angiogenic agents have other effects beyond the vasculature that can contribute to their therapeutic efficacy. For example, there's been a number of studies suggesting that VEGF can actually act as a survival factor for cancer cells, and so it's possible that some of the effects of anti-VEGF therapy might be acting to suppress this growth factor signaling in cancer cells. On the flip side, some more recent studies show that inhibiting VEGF signaling in cancer cells could promote invasion. So this is complicated. It could be that this is very much context dependent. It's also important to point out, and this should be point 3, that VEGF, we now have a lot more knowledge about what VEGF does, and it also signals in a number of other systems in the body. It has a role in the immune system, and also in neurons and in other cell types. And this might be important to consider where we're trying to understand why VEGF-targeted therapy works and what it's doing. And these other effects might contribute to therapeutic effect, or they might be the cause of some toxicities associated with VEGF-targeted therapy. So it's important to be aware that when you target VEGF, you're not just hitting the tumour vasculature, you may be having other systemic effects which could contribute to the efficacy of these therapies in ways that are not well understood, but also could be leading to some of the toxicities that we see. So just to summarize, what I've said is that we really believe that blood vessels are required for tumor growth, and anti-angiogenic therapies have been designed to target these vessels. But these therapies aren't effective in all cancers, and I think we're still trying to understand why they work particularly well in some cancers and in some settings, and in other cancers they're less effective. The mechanisms of resistance, we're realizing, are diverse and are still poorly understood. And biomarkers do remain elusive, although a number of people are working on this. The duration of therapy may be important. So it may be that actually continuing these drugs beyond progression may be of benefit. And I think actually, although people will say vascular normalization is the mechanism through which VEGF-targeted therapy works with chemotherapy, I think actually it's still not clear, and there could be various mechanisms which we need to understand. And also I think it's important to realize that VEGF is not just a tumor angiogenesis factor. It can act as a factor that works on cancer cells directly and also have other physiological effects in the body. And it's important to consider that, I think, if you're a clinician treating patients with these drugs.